My name is Ian Chubb. I'm Chair of the Board of Pain Australia. I'm relatively new in that job, but there does come a time when you have to stop saying that you're relatively new. It's been close to a year now, and I've learnt a lot. I've learnt, for example, that there are roughly 3.4 million Australians who live with chronic pain, and that number is, of course, expected to grow as the population both increases and ages. Around about 45% of those people live with chronic pain, live with depression and anxiety. About 20% of all GP presentations in Australia involve chronic pain, and medications are used to in close to 70% of GP consultations for chronic pain management, and referrals on around about 15% of consultations. There's a big financial cost. It's estimated to be around about 140 billion, with costs in the healthcare system, in lost productivity, in other financial costs, and a reduction in the quality of life of these people who have and live with that chronic pain. So it's a big issue. So we're grateful to the Friends of Chronic Pain, Parliamentary Friends of Chronic Pain. I think that the lesson, of course, that we all know is that to get these things managed properly in a complicated federation and a complicated healthcare system, partly as a consequence of federation, I suppose, is that it does take leadership at the parliamentary end and the policy end of the spectrum in order to get suitable treatments going for that many people, that many Australians who live with that condition. So we're grateful to you and all the participants in this today's program for your interest in this matter. It's big, it's important, and our Pain Australia exists really to advocate on behalf of those people living with chronic pain, but it does so essentially by presenting what options are available, what evidence is known, how well we understand the management issues and the complexity of those management issues, and to speak up for people who might otherwise find it difficult to have a voice. So that's our role. We thank you for your participation, and I'll move straight to Carol. Carol Bennett is the CEO of Pain Australia. She's previously was the CEO of Alzheimer's Australia, the Consumers Health Forum of Australia, the Rural Health Workforce Australia, and the Victorian Alcohol and Drug Association. She's been on several boards and advisory roles through the NHMRC, the Aged Care Quality Council, the Australian Health Practitioner Regulation Agency, Paramedicine Board, and so on. So a lot of experience in that area, and has been CEO for of Pain Australia, which this paper doesn't tell me, but
about 3.5 years.
About 3.5 years. So she's still new, but not as new as me. Carol.
Okay, thanks, Ian. Well, look, managing chronic pain should be a national public health priority, given its prevalence and the impact it has on individuals, on families, workplaces and communities. Pain Australia is focused, as Ian said, on providing our members and the community with quality evidence-based information about pain and its management to support informed decisions in treatment and care. As many of you today will be aware, chronic pain can exact a huge financial, economic and social toll in the community. Those experiencing a chronic pain condition are prone to lower workforce participation and financial disadvantage. They frequently face stigma, social isolation. They have higher rates of depression, anxiety and suicidal ideation. They may be dependent on medications such as opioids to help manage their everyday lives. Neither the individuals affected nor our health system and economy can continue to bear the burden of poorly managed chronic pain. Urgent action is needed, and the National Strategic Action Plan for Pain Management has outlined a blueprint for this to occur. While some limited investment has been made by the federal government for health professional education and training, for some awareness, for some services in rural and regional areas, this is far from adequate. Only 1 in 100 people access best practice multidisciplinary pain treatment, The recent opioid reforms, while important for addressing harm, were poorly timed, and they've left many people struggling to obtain any level of treatment and care. In that context, it's not surprising that Australians are looking to alternatives, including medicinal cannabis, to alleviate their pain. Fundamentally, people living with chronic pain should have access to the best possible treatments and care in collaboration with their clinician. Pain Australia believes that if medicinal cannabis is deemed to provide some benefit by patients and clinicians, taking into account the side effects, the interactions with other treatments and health conditions, then it should be made available to those who will clearly benefit. As with other treatments, regular review to ensure that use is appropriate should be undertaken. There's a high degree of public demand for medicinal cannabis, as you would well know, but the barriers to prescribing as a first-line treatment for chronic pain also remain high. The current level of clinical evidence, information and education for prescribers to alleviate their concerns about medium to long-term use has not been forthcoming. For patients, the cost of medicinal cannabis remains prohibitive for many. Many have argued that it would be better to legalise cannabis for recreational use, making it more readily available and affordable. With out-of-pocket costs already a barrier to effective pain management, expecting people living with chronic pain to pay hundreds of dollars for a script of medicinal cannabis does not provide a solution. Robust clinical evidence is crucial to enhance the confidence of consumers, clinicians and policymakers. Australia's regulatory system demands that a therapeutic good is safe and effective. The current level of evidence for medicinal cannabis in managing pain falls short of what is required to satisfy the standard required. Anecdotal evidence of benefit is growing. At Pain Australia, we've heard from those who found it useful in managing their pain and those who have not. Serious clinical review of the evidence for chronic pain remains limited. In some areas, such as neuropathic pain, there's some evidence to support use. There are also consumer-reported benefits for quality of life, for physical functioning and improved sleep. Self-reported reductions in anxiety and depression, and as Ian mentioned, a comorbidity that impacts up to 45% of people living with chronic pain, can also be seen as beneficial if it helps reduce patient distress. Pain Australia takes the view that Australians have a right to affordable and accessible pain management options. Currently, there are still significant barriers that continue to make cost-effective treatments unavailable to those living with chronic pain. This is particularly the case for medicinal cannabis. We know that some patients gain real benefits from using cannabis to alleviate symptoms associated with their pain, and yet we also know that medicinal cannabis is yet to meet the bar for an established therapeutic evidence base in the treatment of chronic pain. While the prescription of medicinal cannabis as a treatment for chronic pain may not yet be possible, there's a good case for enabling people with chronic pain to access cannabis where it can be shown to be beneficial.
Thank you, Carol. We'll go straight on with Associate Professor Malcolm Hogg. Malcolm is Head of Pain Services, Melbourne Health. He's Pain Australia's Clinical Director and an anaesthetist and Head of Pain Services at Melbourne Health. He's past President of the Australian Pain Society and a member of the Opioid Regulation Advisory Group, TGA, a member of the Victorian Department of Health and Human Services regarding SafeScript, a medication monitoring system, and various expert advisory committees. His specialist experience in pain medicine has been gleaned both in Victoria, of course, but also at the Mayo Clinic in the USA and some years at the Prince of Wales and Sydney Children's Hospital. So Malcolm, please.
Thank you, Ian. Thank you, Carol. I also need to declare that I have done some advisory work for Spectrum Therapeutics. They've formed an alliance with the Victorian government to have a base in Victoria with regards to developing the Asia Pacific region. Whenever I do any education activity, my honorariums go back to my hospital department as I'm a full-time staff specialist. So I have an interest here in that both as a clinician providing care to patients, but also leadership within the hospital environment. I've looked at a lot of the literature and been reading over the years what's been learnt about the use as it's been introduced into both European and the North American market. And a couple of points were of interest. The first is that it's actually skewed to the older population. So where there's quite easy and wide access, a significant number, greater than a third of people accessing medicinal cannabis overseas are greater than 65 years of age. And when they have an ability to look at different combinations, they tend to skew themselves towards using the higher CBD proportion of the medicinal cannabis. So there would appear to be a cohort of people who gain benefit and through market surveillance appears to use it in that older age group. In addition, the studies showing benefit in pain are poor, but there's evidence of improvement in anxiety and sleep, and this drives some of the choices that consumers make with regards to medicinal cannabis. And there's one brain study looking at the effect of cannabis on the brain, and it doesn't change the pain sensory areas of the brain, but it does appear to reduce its connection to the emotional areas. And so there's a theoretical benefit in having less distress associated with a pain condition. And that may be why we see clinically people are choosing cannabis where they're distressed and for their anxiety rather than the pain severity per se. In the North American areas, they're doing some studies looking specifically at the use of cannabis to try to reduce opioid reliance, but in the population studies so far, this has not been clearly demonstrated. And if anything, it's just adding an additional pharmacological agent to people already on opioids. So the panacea that this may appear to be for opioid use does not appear to be coming through in the literature so far. And then lastly, a nice prospective study of a younger population in the North American market suggested that up to 25% can demonstrate problematic use. And I suppose this is one of the reasons that clinicians are so concerned, is that if there's widespread access to medical and medicinal cannabis, then there's going to be a consequence of problematic use in a cohort of those patients. What we found in looking at the evidence is the oils and the oral is preferred, and to clearly get pain benefit, you do appear to have a combination of the THC, which is a psychoactive component, with the CBD. And the CBD, the cannabidiol, does modulate the adverse effects of THC and produces some sleep benefit and anxiolytic benefit. So we're using the combination, but with a preference to a higher concentration of CBD to lower concentration THC, and that we're aiming for people with pain, anxiety, or sleep. The studies looking at this as a population, there's a recent meta-analysis which is mildly supportive. However, it shows us a small effect and a short duration, whereas the Australian study looked at a goal of 30% pain benefit. The number needed to treat were 24. So you really need to treat a large number of people to get a responder, but there was a high frequency of abnormal or side effects, so the number needed to harm was only 6. And so that demonstrates you've got a very narrow therapeutic window, and for many people the side effects come before any clinical benefit. At Royal Melbourne, we developed a policy for the hospital, and so we've introduced this in over a 2-year period. We have been allowing access to medicinal cannabis through the setting of a multidisciplinary team. We're utilising an oral agent and not an inhalational agent because we believe there's lower peak effect and less better side effects, and it's not promoting inhalational use. We're skewing it towards the higher quality TGA approved products which have demonstrated standardisation, and so there's 3 companies that we've been utilising primarily from imported product from North America. What's been helpful for me has been I've had oversight of my ethics committee, and so I've been prescribing within a quality assurance framework. So not only do I get oversight from the TGA in that I have to do paperwork and get approval, but I also get oversight from within my hospital. And so far we've had touch over 40 patients who've initiated medicinal cannabis. There's a number that we've screened and after discussion chosen not to proceed. And of those 40, 22 remain. So not all patients who we initiate on medicinal cannabis remain on medicinal cannabis. And that's due to lack of benefit, the cost implications, and the adverse effects. The ones that have remained and have done well appear to be those with quite severe multiple sclerosis, so they're quite disabled, those after significant cancer treatments and major cancer surgeries, particularly of the head and neck, where they may be having supplemental medications via a feeding tube into their stomach. And interestingly, older people, there's been a number of our patients have been very successful who've been in the older age group and quite frail, and they've tolerated it remarkably well, and it helps them with their anxiety and their sleep, which is often a major issue for the older person with pain. All of these patients have pain of significance and often failed previous treatment. We've not demonstrated any benefit in other medications. They have reduced their healthcare utilisation. Problems have been high concentrations with the oral mucosal spray, the Sativex, which causes high number of side effects. The cost is between $5 and $10 a day. And there's a cohort now who are accessing the private system. So they're going to cannabis doctors and they're paying 2 to 3 times higher in cost, and often with a very truncated assessment. So it's not been performed. And this is a major concern to us, that we may work with patients for their pain management and then find out later that they've separately accessed a rapid access cannabis clinic in the private sector.
Malcolm,
yes.
Malcolm, you're well over 5, so...
Okay. We will stop there. So thank you very much for your attention.
Thanks, Malcolm. We'll go on to Professor Jenny Martin, who's a practicing physician and pharmacologist and academic and healthcare leader with experience in complex regulatory and performance environments in health in the tertiary and in the tertiary education sector. She's director of the NHMRC funded Australian Centre for Cannabinoid Clinical Research Excellence, and which is Australia's first federally funded research centre in medicinal cannabinoids to ensure quality and safety in the implementation of medicinal cannabis use in the community. She's also leading the largest international medicinal cannabis trial and first of its kind, enabling access to cannabis medicines for a significant advanced cancer population in New South Wales Care, and is part of Australia's first medical cannabis trial to produce world-class pharmacokinetic analysis, sophisticated modelling to inform drug dosage and frequency of administration. Over to you, Jenny.
Thank you, Professor Chubb, and welcome everyone, and thank you very much for your attention today. I think just listening to that, it makes me realise that actually Australia is doing quite a lot in the cannabinoid research area, and it's actually been quite an exciting area to work in as a clinical pharmacologist and physician, to be working in the area, or working with pain colleagues, to be working with my geriatric colleagues and paediatric colleagues, to really lift the cannabinoid research up to a level that we actually know what doses of which cannabinoid actually help which diseases and illnesses and symptoms, and which of those doses and combinations are actually more likely to cause harm. We are doing the research in an environment that that aligns with the regulatory framework here for the TGA, so that data can be used then by people wanting to put applications in. But we do actually acknowledge that that's a costly process, and it does actually take quite a long time. But we feel reassured now that people can access cannabinoids through the SASB scheme by their practitioner. That provides a short-term solution for very urgent problems, to enable Australia really to get that research framework up and to get the research data that long-term will provide really good knowledge about how to use them, how to use the cannabinoids, enable some products potentially to be registered and then to be funded. So I definitely hear the concerns of patients about the costs of these therapies, but the way forward that we have in Australia is really through PBAC, and we do know that we actually have to have high quality, rigorous data and registered products to be able to go down through that pathway. So that's why we've really focused on that area of getting the data. And if we can't get it here, we'll be working with international colleagues, which we are doing, to be able to make a contribution to a global effort, but so that we might be able to use that data going forward. I have got a conflict of interest in that all of our work is funded by government, by Commonwealth, generously in the CRE, but also by state health for our clinical trials. I do have perceived conflict of interest in that my husband is a medical director of a young startup in Newcastle called Canna Pacific. and I'm a member of some of the government committees, and all of that conflict of interest has been declared from day one. It's been legally managed, and I think appropriately managed, but just to let you know that that is there. But we get on with doing the clinical research in our area. And I think in terms of the chronic pain, the main issue that we have is trying to separate the different aspects of pain. And we just heard about neuropathic pain and the evidence to support that. And I think because the biology of that pain is actually quite different to some other pain, for example, bone pain and cancer, or some of the chronic pain, which often has overlays that we've already heard from sleep difficulties or mental health issues. So more psychological aspects feeding into that pain. And therefore, from a pharmacological perspective, the physiology of the pain can be vastly different, and therefore you would expect that different cannabinoids might respond differently to each disease. So essentially in the area of pain, we've been working more in the cancer space, but again, trying to tease out those different aspects of pain and which cannabinoids appear to be effective, which ones give side effects. Some of those side effects are wanted, such as a sedative effect with cannabidiol, but also some of them are unwanted, because obviously with THC, which is another component of cannabinoids of the plant, that actually you have difficulty with some of the mechanical and fine motor areas, and depending on how much you've taken, you can be impaired with driving or operating heavy machinery, and that's been a significant issue for patients wanting to take these drugs and also to be involved in clinical trials. But we're certainly working our way through that. But it's a decision, it's discussions we have with patients when they come onto our clinical trials about what the ups and what the downs are. New South Wales Health provide a funded drug for our big cancer study, which, you know, I forgot to put that up on here so that you can all see that if you want to have more look at it later. If I just sort of bring that up now, you can see it's called the New South Wales Care Study. So it's the third line down. And we're actively recruiting for that study. We're excited because, and particularly for pain patients that are in rural and regional areas, they often don't have access to the clinical trials, but this one actually recruits from those rural and remote areas. And we've got some really cool research systems and measurement tools that we can use so patients don't have to drive a long way to be involved in those clinical trials. So that's very exciting. On that slide also, if you can see it there, you'll see there's actually a couple of other websites. So while we've been waiting for the data to provide information to doctors, we've actually provided guidance for doctors on how to prescribe, and we update that information every 6 to 12 months so that, as I said, while we're waiting, patients have access to a product and doctors actually have access to the information that we've currently got. That's all from me, thank you.
Thank you, Jenny. So we'll go on to McVag. Associate Professor McVag is a rehabilitation physician and a pain medicine physician. He is currently the Dean of the Australian New Zealand College of Anaesthetists, Faculty of Pain Medicine. He's Director of Pain Matrix, a private comprehensive pain service in Geelong and Box Hill. In Victoria, Clinical Director of Rehabilitation and Pain Services at Epworth, Geelong, and a conjoint Clinical Associate Professor at Deakin University Medical School. Over to you, Mick.
Thanks very much, Dan, and thank you for the opportunity to address this newly formed group, which is really exciting. I've got a few slides, no conflicts of interest for me to declare. I don't have any pharma connections in my role as the Dean. So a bit of background: the Faculty of Pain Medicine is established by the college, or established within the College of Anaesthetists back in 1998 as a joint initiative between several other medical colleges, including surgeons, rehabilitation physicians, psychiatrists and the anaesthetists. And we have a fellowship that comprises a whole range of different specialties. We espouse a socio-psycho-biomedical paradigm to help us understand pain, which means that, as has been mentioned already, the social and psychological factors that contribute to somebody's experience of pain are at least, if not possibly more important than the biomedical factors. And we have stewardship of the specialty of pain medicine in Australia and New Zealand. to help you understand our thinking about it and about the role of cannabinoids, we have what you could summarise perhaps as the 4 Ps of pain management. The psychology, including in particular educating the patient about what's going on, is incredibly important, and there is evidence to show the more skillfully that is done, the better the outcomes. We have a range of procedures, usually relatively non-invasive, but these days also including implantable devices. We have physical reconditioning and pacing strategies, which is run mainly by occupational therapists and physios, and then probably the weakest of the 4 pillars, if you like, is the pharmacological management of pain. And it's pretty expensive by my estimation. About $320 million of PBS money a year goes directly on pain management products. And to be honest, a lot of that is not very well targeted and not particularly effective as we would like it to be. So, you know, there's certainly room to improve. But again, as the Pain Australia report from a year or 2 ago showed, that medication use for pain is highest in areas which don't have access to clinics which provide the other 3 Ps. So that's not really surprising. Within the faculty, in terms of deciding how we offer treatments, we go by essentially the principles of scientific medicine. We look at, does the treatment that's being proposed actually have a biologically plausible way that it should work? Are there early small studies that show a proof of concept that is encouraging? And then as the studies get bigger and more rigorous, does that treatment preserve its effect size? Most treatments that are effective actually reduce their effect size as the studies get more rigorous. But really, is it able to be feasibly and cost effectively implemented? What do we know about the risks and how do we manage those risks? And philosophically, is this a treatment which involves the patient actively rather than just requiring them to turn up and have something done to them, which is what we would call a passive treatment. So in terms of where you sit cannabinoids within this, certainly there is abundant evidence that we have machinery in our brains and nervous systems which can be manipulated to produce some degree of pain relief by cannabinoid mechanisms. So that is definitely biologically plausible. Are there early studies of the range of sort of 20 to 50 type people to support proof of concept? It's a qualified yes, but they're actually by and large actually quite poorly done, and really don't give an enormous amount of confidence. So where I may seem to be slightly in conflict with Jenny and Malcolm is a different perspective, I might add, because their work with cannabinoids is right on the cutting edge of this. My perspective is more that of the cautious middle of the pack. Okay, so I represent the punter doctors out in the community trying to make decisions on behalf of their patients. So when we get to studies with bigger studies with consistent effects, they either haven't been done, or where they've been done in sufficient numbers and rigours to provide what's called a systematic review or meta-analysis, the effect size is extremely small. To give you an idea, the most recently quoted meta-analysis that I read from a couple of months ago on a 100-point scale, where we would regard a relevant and meaningful improvement on that scale to be 20 points on a 100-point scale. The average positive study for cannabinoids was about 3 points. So yes, you can say there are positive studies, but do they mean much? Do they help much? Not a lot of evidence for that. Or else they haven't been done. And this is, particularly CBD only products. There's never been a randomised controlled trial, which is the basic building block of evidence. There's never been an RCT of a pure CBD product in chronic pain, and yet that is what they're being, pushed as being effective for. So they're very expensive compared to our other products, and they're also not particularly, there's not a lot of guidance, and Jenny spoke briefly about how, and Malcolm as well, about how we need more information to say, well, exactly what types of pain, exactly what types of doses, exactly what types of products. There's really very little guidance for that other than, poor quality evidence and just your own experience. Now, one thing we've learned certainly from the opioid experience is that that you've got to know a lot about the long-term and medium-term risks of medications which you're prescribing. And again, we have only a lot of experience with recreational types of cannabinoids. Now, that may be applicable to pain patients because, as Malcolm mentioned, it seems that the THC component is necessary for there to be even the modest pain relieving abilities which we know about to be present. But really our other sort of pharmacological, our other sort of issue with pharmacological treatments in general is that they do tend to be somewhat disempowering for the patient because it's something somebody's doing to you or giving you, and you're not expected to actually work hard, if you're going to rely on that as your main way of doing it. So what would we like to see that would change our minds about this? I really think we need to stop pushing it as a chronic pain treatment until we actually understand it better, until we have clear guidance as to how it's effective and for what types of pain and what products. We should not be using it widely and routinely. We should be using it in a responsible way. In clinics like Malcolm's and the major, tertiary pain centres, it needs to be really closely monitored. We really do need detailed risk about medium and long-term harm because within the pain management profession, we're still mopping up from the opioid disaster that was somewhat created under our watch 15 years ago. And it's going to take us a long time to fix that up. We don't want another situation like that. Given the really small effect size, I just did a back of the envelope calculation. If you're even going to talk about them being cost effective, they would need to cost maybe 5 to 10% of what they cost now. This is a particularly important one from the average doctor's point of view, is that the industry needs to really not be shown any particular favouritism because in pain, we're used to seeing drug treatments come and go. They look promising, and then when you try and scale them up to using in chronic pain situations, they go nowhere. And we've seen at least probably 20 of these in the last 5 or 6 years where drugs look really good. They have a very plausible mechanism of action. They go through the pharma development process and they fall at the last hurdle when you try and introduce them into clinical use. So we would like to see, to increase the confidence of pain specialists in the industry, we want to see them doing the same thing as everybody else has to. We want to see them having to spend money to develop rigorous trials before they go to market, not doing them afterwards when the horse is already bolted, because we fell for that with opioids. We don't want to fall for it again with anything else. But just to be slightly provocative as well, if we've got lots of money to spend, I'll wind it up now. Thanks, Ian. Okay. This is a list of 10 things off the top of my head. The ones with an asterisk would need some active participation from states. But these are things which we would probably rather the money be spent on, which would be evidence-based, directly beneficial treatments for chronic pain.
Okay, thank you, Mick. Thank you, colleagues. That was very interesting. We're now open to question and comment from anybody. We don't have any questions yet. Carol, are you going to?
You can use the chat function to type in a question, and if you do that, we can direct them where they need to go.
We'll arbitrate as needs be. So, are there any questions? Are there any comments?
Comments, yeah.
So I have one, just a very simple question for any of you, but we talk about cannabis oil, we talk about the product and what it contains, but maybe members of our audience who are not specialists in this area don't know much about how many cannabinoids there are in extract. Yeah. And picking out the ones that are effective and in some chronic pain conditions might be just useful information to share.
I can start on this, but I'll probably need backup. I think there's at least 80 active cannabinoids in the plant, probably over 100 actual cannabinoids that we know of, but not all are known to be active. But I guess we're kind of lucky that the plant has been around for a while, because that has given us information into ones that look like they are more active. So I think in terms of, that's why I'm coming back to the physiology. We actually have to know what we're treating in the chronic pain to be effective. So the chronic pain, as we've just heard from Mick, is a completely different biology to someone who gets a nociceptive stimulus, who burns their hand and has a change in a peripheral signaling pathway. So I guess it depends on which symptom you're looking at in terms of which cannabinoids are active, but there's probably two two or three that are mainly active: the THC, which is more the one that causes some of the psychotic reactions that we've seen, and the cannabidiol, which is seems to work more in the immune system, and it does have sedative effects and also cognitive impairment, but that has more anti-inflammatory effects, which might be relevant for some types of pain.
Okay, thanks. It is one of the problems with the clinical trials such as have been done and perhaps into the future, and I guess you've said this, but it probably needs re-emphasising, is the variation in product. In my pretty minimal research on this topic, so I don't claim any real expertise, but one of the striking things for me was that the content of the product seems to be very variable, essentially depending on the producer. Now, I don't have any particular problem with that. I mean, I understand the issue, but in terms of doing clinical trials, I'm looking for a thing that has, bigger impact on neuropathic pain, for example, versus something with bone cancer, and so on. It seems to me that one of the difficulties is the variability in product and understanding what that actually means for the pain condition being treated.
Yep. Well, I can speak on this unless one of the others wants to, but yeah, that's been an ongoing problem for us in the clinical trials. I mean, the products coming in, which have been from overseas, they do have to meet a minimum standard from the TGO 93, so that we know that there is minimal heavy metals and other impurities that we give to patients. But the data that we don't have is on the stability of the product. So that is to say, is the product we're giving patients at the start of the trial the same as what it is at the end? And that's particularly been a problem for the dry leaf product, because even though it's been in the freezer, it does still oxidize over time, and that might well change the constituents of that plant. So again, I talked before about meeting the TGA regulatory requirement, but if the actual product at the end of the trial is slightly different to what we started with, then that means that data is not as useful as we started out with. But I guess we couldn't wait for 2 years to look at stability data, which is usually what the pharmaceutical companies would have done before they even started on a clinical trial. So essentially, we've gone straight into clinical trials without having all of the usual drug development work that we usually would have had to know we're getting the right product, a pure product, a stable product to give to patients. So that's definitely been a weakness.
Okay. One other question. Have we got any others yet?
Maybe ask the co-chairs.
But one other question that I have is how does a prescribing doctor weigh risk and benefit to somebody with severe chronic pain? So let's say bone cancer or extreme neuropathic pain, for example, discussing with the patient who's read that medicinal cannabis might help them, and they're, let's say, in their 40s rather than, later on in life. So what sort of conversation do you have about risk and benefit? Malcolm, probably?
Yeah, so thank you. Our process is not slow, and I think that's a key, that we do multiple assessments. We have more than one clinician have input into the decision, and also the family of the person involved needs to be part of the decision-making process. We go through a checklist of all the adverse effects, but also similar to how we should be doing with opioids, looking at when we would be comfortable and what we're looking for, what the patient's looking for and their goals, and almost preemptively say, this is what we'd accept and this is what we would not accept. Mm-hmm. And then it's a trial, and like opioids, it's a trial to see, does this provide any benefit? If it doesn't demonstrate benefit, then we don't maintain it. I am fortunate that I'm dealing with patients who are in a tertiary centre, so they've already had most treatments or have considered most treatments, so they've gone through that risk-benefit analysis for other treatments or experienced it already, and that's what's brought them to the decision or discussion about medicinal cannabis, and so we tackle it the same process.
So, but the benefit, Malcolm, then is subjectively their experience, the patient's experience.
Yeah. Now, that is true, but we also do some baseline measures of their weight and their exercise time. So if they can mobilise, we do a walking test. We do independent self-report pain questionnaires looking at that, plus a sleep questionnaire, and then we replicate that. So we're trying to get some form of consistent assessment and review process so that we can compare it. And on reflection, we can say your scores on this were X, but you were the same when you started it. I don't believe this has given you benefit, so we should look towards weaning or stopping this.
Oh.
In practice, it's the cost. I mean, if they have to justify it, the benefit to themselves for the cost, and they make that internal decision about, is this worth my ongoing cost?
Yeah. Thanks,
So
Malcolm.
I think, Ian, the issue also is that, you know, nobody would say that it's particularly unethical or problematic, you know, to be trialling off-label or experimental drugs in people who've exhausted all of the other possible options. But the issue is that if you look at the projections of uptake, you know, in the industry prospectuses, they're not expecting a couple of hundred people a year in Victoria to use. They're expecting tens of thousands, if not hundreds of thousands of people, and that, I think, you know, that I think is a very different group of patients to the ones that Mark was talking about, or that you were talking about. So you know, making sure that people actually have had you know, adequate trials of evidence-based multidisciplinary care before they default to trying things that are, you know, don't have a clear role but may have some benefit. You know, those numbers should be small.
Thanks, Mick. So we've got a couple of questions from attendees. One is there a reason a special access scheme is still ongoing? Numbers are quite high to justify not mainstreaming.
Yeah, but the problem is, oh, sorry.
Yeah, go on. Yeah.
I think the problem is that we either haven't got data, or we've got data that doesn't support registration. So I guess until we get some data that's supportive, and on the bottom of my slide, I just have the latest review of cannabinoids and pain management, which summarised all the literature. There's really, even internationally, not compelling evidence for most types of pain. In fact, there's not any for any of it at the moment. There's certainly some suggestive in neuropathic pain, and there potentially is for some of these symptoms like anxiety and the sleep and the appetite, which can contribute to the pain. But I think that's sort of our issue, that until either we've got the data, and then also we've got to have the support from a company that has got the time to put together a dossier, not just the time, but actually has the skills in their group to write it. Because it's not a pharmaceutical company that's got a pharmacologist and a pharmacokineticist and a chemist and a clinician. These are often groups of startup people wanting to make money out of a business, and they don't then have the skills to be able to write an application to get a drug registered. So I think I think we're still a wee way away from registered products. Having said that, we do have a registered product called Sativex, an oral mucosal spray, and maybe the discussion is why people are not using it in such a way that it means that indication can be extended. Is it an efficacy issue, or is it a toxicity issue, or is it a market issue? I'm not sure, but I think there's a few conversations to have around this, but I suspect that's why the SASB is continued, because we don't have the evidence to be able to provide it as a therapeutic. And we do have concerns. And just one point I didn't bring up before, which is around the toxicity. There's actually data that's come out, and it's available for you to look at, patients that are having immunotherapy for cancer. Now that costs the country a fortune for these new drugs. If you take one of the cannabinoids, your outcome is much worse for melanoma, because for these drugs to work, these immune therapies, your immune system needs to be switched on. So if we then take a cannabis product and switch it off as an anti-inflammatory, which may be helpful for arthritis or other things, then your cancer therapy may not be as effective. So I think there's a real risk here of potential harms. And I think that's where Mick and I think it was Mick that talked about the concern that clinicians in this area have. I don't work in pain, but I think certainly there's enough concern that there's a toxicity profile that we haven't really looked at in the medical cannabis space and the vulnerable populations, not in recreational users. and we need to understand that before we can safely make an appropriate therapeutic decision.
Thanks, Jennifer. There's a question that is a fairly critical one, I reckon. It appears too easy to get caught up in conversations around legalisation of recreational use as opposed to the efficacy of medicinal cannabis. How do we ensure we keep the conversation separate? There's a $64,000 one. Meg?
Yeah, this is something that comes up all the time for the faculty, because, you know, we are experts on the evidence to do with its use in pain medicine. And, you know, we don't claim to have any sort of view about, you know, recreational or other use. Those are political and social and economic questions. And to an extent, they're public health questions as well, because there are some evidence of altered patterns in public health in states in the US, for example, where recreational use has been legalised. So it's critically important, in my opinion anyway, to keep the conversation separate, acknowledging that in a lot of areas, particularly overseas in the States, the medicinal use has been a sort of an icebreaker, if you like, leading to further liberalisation of attitude. So that's how it got conflated with it, from a lot of the lobbyist arguments or the advocates' arguments from the States, where they've done that repeatedly in several jurisdictions. And so, you know, we're very anxious to make sure that if we're going to use it for pain, it's got to meet the standards of our other treatments for pain. Otherwise, you know, let's have a broader conversation about harm minimisation and legalisation. So that's nothing to do with its use in pain or whether it's useful or appropriate in pain management.
Thanks, Mick. There is a question about why overseas jurisdictions have legalised marijuana and what are the barriers in Australia, but I think that does actually then conflate the two issues that we were just talking about. It's the medicinal use versus the recreational use in a way. One of the confounding variables seems to me with the medicinal use is that many of the products contain variable amounts of the psychoactive compound THC. And I know that there are plant breeders who are attempting to breed plant with all of the other cannabinoids without as much of the THC and so on. And I guess that's an area that will continue on as this becomes more likely to be in higher demand. Mick, there is one that refers to a point you made. If the market size estimate is so large and consumer demand so high, should we not be listing it as a proper medication?
Well, again, you know, I think the thing is we have ruled about this stuff, and you know, for many people, the medical cannabis debate is the first time that they've had exposure to the complex world of the regulation of medicines. But you know, it's very commonplace in our industry for companies to be working on a whole lot of different products and compounds, and some look really exciting, and you hear about these things in conferences for years before they actually make it into a final product. So the thing, you know, just because a lot of people want it isn't really a good enough reason to say that it's now suddenly safe and effective. You know, it has to. We've never treated therapeutic products as casually as what we're currently treating or potentially treating cannabinoids, and you know, I think it's really important that we continue to insist on the standards that exist to make sure that first of all that people are kept safe. Secondly, that we're not selling them false hope, or we're not giving them false hope by using products which we think probably work, but we can't say for sure do. And that trust that people place in the doctors and the clinicians who look after them is a major reason why the regulations are so complicated.
Yeah. Malcolm, can we say that it's effective for neuropathic pain? In terms of the presentations, the question goes on, it sounds like the studies are not of high enough quality, but can we say that it is effective for neuropathic pain?
I don't think we can say that at this point in time, no. If you look at all the neuropathic pain treatments, the expectation of drugs that are already established in this area is only about 50% of patients respond, and cannabis is even lower than that. So I think you're looking at maybe 1 in 4 or 1 in 5 patients may have a partial response if they have neuropathic pain. So neuropathic pain is hard to treat. And then the component of that neuropathic pain in responsiveness is also hard to assess and often varies per person, and it may vary within the same person over time. What we could say in the studies that have been done is that in those with neuropathic pain, a subgroup may respond to some degree of a component of their experience, and that may not be necessarily pain. It may actually be the distress or the sleep disturbance that goes with their neuropathic pain. So their overall pain scores or their experience scores, quality of life may show some improvement, but it's very hard to clearly link it to the overt sort of preparation that they've used and to detect which patients are going to respond and which patients are not.
I guess it would be a fair follow-up question to say, given the complexity, will we ever be able to distinguish? Given that the people living with chronic pain have, you know, anxiety, they have insomnia, they have all these things.
I mean, they don't all, just a higher percentage than the normal population.
Yeah.
And that's the point of doing rigorous trials, is that you even out all the confounding factors. And you know, that's why when you do larger, more complicated studies, the effectiveness of the product seems to reduce. That's a normal thing that we're used to seeing in drugs that work. So there are good tools, and there are smart people like Jenny who run these sort of trials. And so, you know, the thing is that it is possible, and pain research has exploded in the last 15 or 20 years. And I think, you know, there are multiple ways to assess the effectiveness of medications. The studies just need to be done.
Jenny.
Well, thank you. Yeah, look, I think that's a really good point that was made, and it relates to having a placebo arm in a clinical trial. And when the question came about the neuropathic pain, although it does sound really interesting and supported by the animal data, the data is really mainly observational trials. And we know that when we start something for people with pain, most of them get some benefit to start with, and that wanes over time. But we also know from the cannabinoid trials that have had a placebo arm, up to 40% of people that are not getting a cannabinoid actually get the same benefit as the people that are on the cannabinoid. And that's not unexpected. In fact, most clinical trials with the placebo arm, about 30% of people get a benefit even when they're not taking the drug. So I think before we can make any claims that it's better than just doing nothing, we do actually have to have the final clinical trial, which is comparing the cannabinoid that has been, we've got the dose right, we know how to use it, but then comparing it to standard of care, which may be, it depends on what disease it is, but only then do you know the comparative efficacy of adding on a cannabinoid to the current standard of care. And I think just looking at the observational data that's out there, and it's been brought up by Malcolm and Mick before, that actually people over time stop taking their cannabinoid. Unfortunately, at the moment, we don't know whether it's because it doesn't work or because they get side effects or there's other reasons, but certainly the initial excitement about having something new to try often wanes very quickly.
Thanks, Jenny. So we have one more question, colleagues. It's most consumers don't even know they are taking opioids. How will they differentiate between different strains of medicinal cannabis? That's called a doctor-patient relationship, I guess, but still. Malcolm?
Yeah, I think there's a role here for the TGA, and if they are going to do this properly, they should be aggressively auditing what they've done so far and how many permits they've given, what products they've been utilising, and then testing those products, because even batch-to-batch variability is significant, and what's claimed and what's provided, I think is important to understand better, so that we get to a point where we can say, well, I'm prescribing this amount of this component of cannabinoid 1 and this amount milligrams in cannabinoid 2, so that we can get consistency and confidence in what the current market. At the moment, there's too many different products, they're too variable, and they're not necessarily being aggressively checked in order to all the way through this program.
Thank you. Colleagues, we have no more questions on the screen, so perhaps I could invite David and Wendy to make some closing comments or any overarching comments you'd like to make. So you go, David. Yeah.
Excellent. Look, I should note that I represent an electorate which is unique in that it actually includes the current side of TGA and also has part of the electorate that's been hoping that they might be able to possibly have a plantation that they could use for medicinal cannabis, believe it or not. Before you're wondering whether it's down in Tuggeranong or in Woden, it's actually across on Norfolk Island. But it's... out
of sight, out of mind, eh?
Look, for me, look, thank you first to all the participants, and apologies for the divisions that have been happening during the Zoom. I think you'll find that there'll be quite a few members will be looking at accessing the recorded version of this presentation because there has been a fair bit of chatter, certainly amongst the Labor caucus about these issues. I mean, one of the things that always comes to mind for me is not just in relation necessarily to medicinal cannabis, but elsewhere, is actually about the amount of pressure that's on the TGA, and often it seems unreasonable pressure from all different parts of not just industry, but from other pressures too. And I'd be interested in whether the panel has any views about whether TGA is sufficiently resourced. Does it need more resources to actually assist in terms of being able to get through the hoops that we want? We want hopefully medicines or the like that do meet the efficacy requirements get into actual usage.
Yeah. Oh, well, I mean, I'm on the record for being a fan of the TGA and acknowledge the work that they have done to keep our patients safe. I think that Professor Skerritt and his team have done an incredible job because we're the first country in the world to actually look at this as a therapeutic option for patients in a clinical care setting as opposed to more recreational use. And so he's definitely been against it all internationally as well. And right from the beginning, he stepped up and he met with the clinicians and got guidelines or guidance, I think, to help get us started. And he's helped deliver a framework, I think, that's made the research possible in Australia. And I think that's helped our current research. But I definitely acknowledge that they probably haven't been resourced for this. There's been cutbacks a lot over the last 30 years or so. I can't really comment on that, except that previously there have been staff that have been able to look at SAS A and B applications and audit those. And also with pharmacovigilance, which is another area we wanted some help with, which is essentially looking at the patients that get the script, what happens to them. And we know that the systems and the people to help with the working party on that haven't been available to help. So I definitely support that, but I don't understand the bigger context of health in which the funding goes towards the TGA.
Thanks, Jen. Colleagues, we're about to run out of Zoom time, so I'd like to just add a thanks to you all, to David and Wendy for co-chairing this group. I think it is an important group, as we've discussed. There are very important issues. There's the question of managing chronic pain across the full spectrum of pain conditions and making sure that people have all the mechanisms available to them shared with them and decisions made to give them benefit. I thank particularly Malcolm, Jennifer and Mick for their presentations. I think I can't speak for all the others, but certainly I learned a lot from you, and I thank you for that, and I'm sure the others do too. And I thank the participants for being interested enough to join into this and to hear about what a group of specialists who are directly involved face to face with these issues on a daily, regular basis anyway. And it's not simple. There are people who need help. We need to help them the best we can. We need to be sure that they have available to them the best possible advice and be aware of the treatment options available to them and the consequences of those treatments, whatever they may happen to be. So thank you all, and I'm sure we'll meet again sometime. Thank you.